Good morning, my dear friends. And today I'm going to share some important insight, which I'm going to speak in one of the meeting, and that is with respect to it's based in the cardiogenic section, and this topic is related to the cardiac power output, CPU. Uh, this is one topic which has never been taken into uh, per se, either in the use, I would say the conventional use, or it has never been spoken about to an extent that it should become a tool for monitoring for us. Now, what do you mean by cardiac power output? Now, it's basically what we need to understand, that heart is a hydraulic pump, right? It's a pump. The function of the pump is to deliver. Now it delivers in two important variables. One is the volume, obviously, which refers to as a stroke volume, which if multiplies by the heart rate becomes the cardiac output. And this cardiac output, whenever it's going to is going to happen, it's going to exert certain pressure over the arterial structures, over the arterial wall, which is going to be reflected in terms of certain pressure. So cardiac power output, or the power of this hydraulic pump, is defined in terms of these two important variables. It's a product of your cardiac output into your mean arterial pressure. So this is an important tool. Why? Because if you go by the 2004 study, which is the shock study, and who has been speaking about, I think this is the first paper which has spoken about this importance of cardiac power output. And what they have been able to decipher is that this tool has the strongest hemodynamic correlate, which reflects the mortality potential in the patient with cardiogenic shock. So when the patient is coming in shock, we all know there are four types of shock, and we are talking particularly the cardiogenic shock. So what they have seen, that when you have to define the prognostic, uh, when you have to define this or attach the prognosis to the cardiogenic shock, this is one tool, or this is one parameters which defines uh, or which has been correlated in the best possible way among all the parameters which has been given. Somewhere we have been trained to think that the blood pressure has been uh, the reflection of how do the patient is behaving. But what we need to understand, that the blood pressure is in fact dependent upon two important variables, which is your cardiac output and systemic vascular resistance. So if you're just accelerating your blood pressure by improving the systemic venous resistance, or accelerating onto the SVR, but without working onto the the cardiac functions, this may be able to give you a false representation of the blood pressure, which is leading to good perfusion. But this may not be the real case, or this may not be beneficial. It's something like you are imposing so much of resistance to the failing heart that eventually it's a recipe for the heart failure. So the point, or the reason why I'm having this small discussion with you, is you can understand that how important this cardiac power output is in terms of defining the mortality potential, or the or eventually to define the prognosis of the patients who are coming in cardiogenic shock. Now, this cardiac power output is in the resting situation, it is close to 1 watt. And obviously, under the stressful conditions, under the pharmacological support, especially when there is an exposure to endogenous catecholamines or exogenous catecholamines, it can increase up to 6 watt. What this study has been able to delineate is when this cardiac power output has been less than zero point 0.6, to be precise, it is 0.53 watt. They are the cases who have been the sickest, and doing any intervention in them has not given them any mortality benefit. So you can refrain from choosing those patients for doing any advanced intervention, especially if you're talking about the mechanically support or the mechanical circulatory assisted devices which you're talking about. So what is this cardiac power output? As I said, it's a product of your cardiac output into your mean arterial pressures, which is divided by the 451, which is a constant. And in the resting situation, it reflects 1 watt. And in the situation of stress, it can go up to 6 to 7 watt. And it is this parameter which has the potential, or in fact, in the present standards of medicine, this is the best way you can draw, you can represent the pumping ability of the heart through any metric which is available to us. Now, in order to define this cardiac power output, there are 4, 5 important things which I would like to share with you. One, knowing the mean arterial pressure is not going to be a difficult task, but how you're going to measure the cardiac output, that is something, it's tricky. As we are there in the present era, we have been talking about measuring the cardiac output through the non-invasive means, which looks very eloquent, which looks very easy in order to say that because it's a non-invasive, it's not going to harm to the patient. But the problem here is that the non-invasive cardiac output monitoring in multiple papers, especially in the last decades, have shown that it doesn't correlate exactly when it comes to the invasive data which you draw from the catheterization of the heart. Now, why it is important? Because unless and until you're very precise in estimation of your cardiac output, uh, your reflection in terms of your cardiac power output may not be true. Not only this, the non-invasive cardiac output monitoring has a limitation in terms of the expertise and your ability to replicate on time to time basis. Why? Because many of the patients who are the sickest in cardiogenic shock, they may be spending time on mechanical ventilation. It will be difficult for you to repeat this test on time to time basis. And even if you're doing it, it may not be able to give you the true representation. The reason behind, because your 2D echocardiography has a lot of confounding factors in the form of patient on positive pressure ventilation is going to give you a bad view. Slight change in the position is going to give you a different estimation in terms of cardiac output. There may be a difference when it comes to the user experience. If the user is different, you may actually underestimate or overestimate the cardiac output. So that is where the trick will be. So the point here is that in order to understand that what you can do to define this precise cardiac output, you need to know first what is the best way to measure the cardiac output, and that is based on your thermodilation technique. Now, the next question comes, are we in the era where we should be actually using the Swan-Ganz catheter in order to define this invasive data, or whether it's going to give you any mortality benefit or not? Now, this is an interesting concept, and thank you, Srinivas Sambindam, who has given me this topic to share in this coming Hyderabad Intensive Care Symposium. And it has given me the reason to dwell deeper into the subject. The data which has been given in ESCAPE trial, which was, I think, in 2004, where they came and they reached the conclusion that Swan catheters, they may not be able to give you a mortality benefit. One, moreover, it is associated with its own complication in the form of, leading to your some conduction blocks, sometimes traumatic ruptures, sometimes the bleeding problems and those kind of issues. Having said so, the important point which they have, or maybe we overread at that time, was that this data has been used only in the patients who are been having a heart failure. When you read about the heart failures, The heart failure, especially in the European Society of Cardiology 2021 guidelines, they claim that it has the multiple phenotypes. And if you see the commonest what we read is acute decompensated heart failure. The second is when the patient has just acute pulmonary edema, which represent mainly because of an acute rise in the SVR, which happens in hypertensive crisis. Then there is a entity which they are talking about per se acute RV failure. And last but not the least, you have a biventricular failure. And these are the kind of a situation which you will deal in a different hemodynamic profiling or different clinical phenotype variant, which you will have on the basis of your examination and on the basis of the data which you have. The point here is that this data uh, or this trial, when it came into the picture, it has seen mainly these four, the subset, but it has vehemently excluded the patient with the cardiogenic shock. Now, this is something which was surprising. Although it has not been seen to improve the mortality in these cases when it comes to the patient with acute heart failure, but when the same representation has been done in the recent, especially in the last 5, 6 years, the 2017 meta-analysis and even the American Heart Association paper, which has been published by Gabrin. I think Gardman is the person who has done significant, impactful work when it comes to the invasive catheters, especially the Swan-Ganz. And he has spoken very clearly that when the patient has been having a cardiogenic shock as a subtype to a patient with acute heart failure, they are the patients who are the sickest. And because they are the sickest, they need very precise estimation of their data. And if you're very precise in terms of your estimation of data, including your, the right heart catheterization data as well as the left heart catheterization data, this hemodynamic profiling has a substantiate impact onto the patient outcome. It has translated into a mortality benefit, and these are the two important papers which I'm going to share soon with you, and where it has been clearly delineated that how does the evidence is in favor of this invasive catheter. So, my dear friend, the point here is that what you need to understand that invasive catheters, they have their own importance, especially the Swan-Ganz catheter, especially when you are trying to know the hemodynamic profiling. This hemodynamic profiling or knowing the hemodynamic subset, apart from your clinical subset, in the presence of having a dedicated shock team, in the context where you're able to make early diagnosis when your patient is coming in sick, helps you to actually improve the mortality. And this again has been elucidated well in the recent papers which has got published. This is one important point which I wanted to share with you. The second thing is that when it comes to acute cardiogenic shock, or when we are talking about the patients into A, B, C, D, E profiling, which American Heart Association and even the Society of Coronary Angiography, which is a part of your American Heart Association, they have also given this profiling. And what they have said clearly that if you are using this Swan catheters, especially for the hemodynamic classification profiling, also when you're planning to introduce the mechanical circulatory assisted devices, even when the cases when you're trying to wean them off, also when you're planning to take the candidate for the transplant and you're taking this therapy as a bridge onto transplant, these invasive catheters, they do help. However, the catch point is that these catheters, they need their own expertise and they have their own learning curve. And that is why the reflection of these results is highly dependent upon the centers which are using them. There's another important point which I wanted to share with you is that this cardiac power output is something which is a reflection of your acute mortality. It's more specifically the acute short-term mortality in a patient with cardiogenic shock. There's another important parameters which is known as pulmonary artery pulsatility index, or it's also known as popularly as PAPI. Now, this is something which where the CVP is divided by the pulmonary capillary wedge pressure, and if it is more than 0.86, it reflects the significant RV. uh, compromise. So the point here, what we are trying to learn is that how we can get better across when it comes to the patients who are coming in cardiogenic shock. And the patients who are coming in cardiogenic shock, how can you define better whether they can be resuscitated well, and whether they have what kind of intervention is going to help them in terms of their survival, and whether you should take the help of any circulatory devices on the basis of any specific metric. Maybe this cardiac power output is one of them. So the next time when you have a patient who is having a complex shock, more specifically after the acute myocardial infarction, having a bad shock with a bad perfusion markers, you want to do the hemodynamic profiling. Non-invasive cardiac output monitoring is not going to be very reliable in these cases. Moreover, it is very less reproducible with the passage of time because of the complexity which is associated with it in terms of doing it again and again, requiring reorientation of the windows. In that situation, where your each and specific therapy has an important role to define and redefine the patient course, there you want to have this precise data. And when you have this data, when you once is available with you, one, it is going to help you defining the need for your mechanical circulatory devices, which is nevertheless is based on many other parameters apart from CPO. Plus, it is also going to be helped, or it is also going to help you in defining the prognosis or the impact what your patient is having in terms of the severity of illness. So that is what I wanted to share with you. Thank you, and I'm going to upload soon the presentation over it, and maybe we will have the certain question attached to it. Thank you. Bye bye.